With the class, I request all the online students, please turn on the cameras. This blank screen doesn't look very nice. And few of you have submitted the assignments by email. Rest of you can submit it by email for the feedback, or you can submit in the class also, those who are coming here. Okay. And I'll be correcting it, giving the feedback of basic things. And those who have not done it, do it by next class for thyroid. Otherwise, things getting piled up. You made it? Okay. And regarding the diagrams in thyroid anatomy, the most important, there are like two diagrams. One is the transverse section, which is given in video2, and the second one is about the blood and nerve supply of thyroid. And apart from that, applied aspect, if any diagram is needed, you can make it. It's say they only ask about the applied aspect. There you are going to talk about hyperthyroidism, the carcinomas. You can write that also in applied aspect. You can make a small diagram or just some kind of table or the graphical representation if you want to. If there's only a question on applied, if the applied is as a part of some other thing, skip these. If it is only for 10 marks, right? So just submit your assignments here, and I'll correct them and give it to you in the next class. Take. Okay, last time we left at hyperthyroidism. We have to start hyperthyroidism today. How do you define hyperthyroidism? Anyone online? How do you define hyperthyroidism? What will be the definition of it? Increase in thyroid hormones. Okay. Huh? Just the excess of thyroid hormones. Okay, that becomes abnormal itself, out of the range. Okay. And is there a difference between T3 and T4 thyrotoxicosis or hyperthyroidism? When we define hyperthyroidism, what will be the exact definition that you should be writing? What hormones, like you'll write about thyroid hormones. Okay, abnormal. Now thyroid hormones, when we talk about thyroid function, there are TRH, TSH, everything. Not all. So which thyroid hormones we'll talk here? T4. Okay. When it comes to hyperthyroidism, we'll talk about both T4 and T3. But if they specifically ask, there's a question on thyrotoxicosis. So mostly thyrotoxicosis is due to T3, but otherwise both of these. Is it showing black to you, the color? Okay. All right. So hyperthyroidism, you can write down the definition. It is defined as a thyrotoxic state where there is increase in T3 and T4 thyroid, free T3 and T4 thyroid hormones. Okay, underline the word free over there. Why we are stressing on the word free here, but we are not stressing about it in hypothyroidism? We are not very concerned if it is whatever is the value, but why here?
Will lead to symptoms.
Yeah, it will lead to symptoms because these are the inactive form. T4 usually it is an inactive form bound to the proteins, plasma proteins in the circulation. But when it goes into the periphery, that is into the tissues, and there when it interacts with the receptor, before that it gets converted into the active form, and that active form is what we call as free. It is unbound free form. Okay. It is unbound and it is the active form of thyroid hormone. This is the free form, is the one that leads to all the kind of symptoms that participate in the normal metabolism also. So for all the physiological function, it is the free hormone that is responsible for it. So when we are talking about hyperthyroidism, we'll talk about both free T4 and T3. If there's a question particularly on thyrotoxicosis and that the state, if they're not mentioning about T3, talk about T3 more, but also say T4 will also be high. Okay, T3 is more potent, it causes more symptom, it is more active, and that is why when we are giving the hormone replacement therapy, we do not give T3, we give T4, because T3 is very potent. It has to be given in high doses. It is expensive to buy also when you prescribe, and it leads to symptoms very quickly. Only in some specific cases we have to give T3. Otherwise, we don't prescribe. Right. So what are the symptoms of hyperthyroidism? Okay, exophthalmos is okay. What else? Common one. See, goiter, when we talk about goiter or thyroid swelling, there are certain cases, not all the cases of hyperactivity of thyroid gland will have goiter. Not everyone. No? So goiter is not a common, anything common.
Palpitation, tremor.
Yeah, palpitation, tremor, the things related to increase in the basal metabolic activity of the body. So all of those symptoms will be here. Okay, somebody, Sushmita is writing sweating, palpitations, hot flushes, increased BMR, weight loss. And weight loss happens despite increase in appetite. And that is the catabolic effect. Okay. What else? Now you talk about your exophthalmos. Okay, there is sympathetic nervous system gets activated, and there is a specific lid lag is the term used, and there is exophthalmos also related to it. These are all the symptoms of sympathetic activity, and you can actually divide the symptoms into hypermetabolic state and sympathetic state. We are going to take notes like that only, but while you're writing, start with hypermetabolic state because those symptoms are the first to arrive, and the sympathetic overactivity gets more pronounced in the severe cases or at later stages. It is not like yesterday the patient got into hyperthyroid, today will have exophthalmos. This doesn't, but he will have the increased metabolic rate instantly. That things happen first. So when you're writing answers anywhere, you have to follow a pattern. It should go in one specific pattern. Whatever is happening first, you talk about that first. Okay. Okay. What are the common causes of hyperthyroidism? What causes hyperthyroidism most commonly? You have discussed any classification where there is increased thyroid hormone, increased hormone, decreased hormone. So what are the reasons of increased thyroid hormone hyperactivity? It's an abnormal state. Now release of the hormones is one of the effects of some disease state that is happening. So what are those? Graves' disease, all right. Solitary toxic nodule. Anything from online students? What are the causes of hyperactivity of thyroid gland? Anything else?
Drugs related.
Drugs, yeah, they also cause it. They sometimes they don't really cause the hyperactivity. It is just that they mimic the TSH receptor work, so there is a hyperactivity. What else? Okay, somebody pituitary adenoma and carcinoma, that comes into the secondary features, but not all the pituitary adenomas will cause this. Only the very well differentiated ones. Okay, carcinoma, well differentiated carcinoma can cause it. Because what happens in well differentiated carcinoma, we discussed in the last time that more well differentiated it is, more normal function it is likely to have of the organ. We read in the malignant states, so that is also one of the reasons. Okay. You should know about the causes, because if you get an approach to a hyperthyroid patient, you will have to distinguish the differentials. These become your differential features. Rest of the things you will rule out on given on the specific history, but at least you should know about 4 to 5 differentials to write, and start with writing the most common which is related to your history. Say they are talking about a brute is more common in grapes. It can happen in other things, it can happen in solitary toxic nodule carcinoma also, but most commonly we correlate brute with the Graves disease. We'll discuss Graves, you'll get it. So these kind of things, when they are written in the history, you correlate with that. Any disease that you are going to read from now, because after this today's class we're going to go a little fast, so any disease you learn, for every disease you should know at least 4 to 5 differentials, and they should be on your tips by the time we end with the course. Anything I give you any symptom, you should be able to label at least 2 to 3 illnesses related to it, so that when the question comes you don't get into a panic state. You should have at least something going on in your mind, and while you're writing you will be able to make a better flow chart. नहीं तो ऐसा होता है, the students are making a flow chart, by the time they come to end they'll realize, oh, there was one more symptom, I could have made it a better flow chart like this. What I'm going to teach is how you will make the flow charts, but it is not necessary that the exact question will come in the exam. ठीक? You look little confused. What happened? All right, so first we'll write down the clinical features and then we'll start. Okay, first what you have written so far? You have written the definition of hyperthyroidism. Just write down the causes of hyperthyroidism. Okay, the causes, most common is the Graves disease. Graves disease, multinodular goiter, solitary thyroid nodule, adenomas, thyroiditis, increased uptake of iodine, then you can get factious thyrotoxicosis, that is due to some extra dose of thyroid hormone. Okay, these are the causes of hyperthyroidism. Now write down the clinical features of hyperthyroidism. As we'll write, we'll also discuss how they are happening. In clinical features, first one will start with the hypermetabolic state. Now the normal function of thyroid, how many of you remember that? The normal physiological function.
It is an anabolic hormone. It increases glucose absorption and gluconeogenesis.
It is both anabolic and catabolic. It also has catabolic functions. It has basically, when we talk about thyroid hormone, it is not all about your weight gain or weight loss. Thyroid hormone physiologically means it regulates the metabolism. Okay, it is related to the metabolism. Usually when we talk about metabolism, or say somebody's talking metabolic syndrome, the first thing that comes to everybody's mind is insulin. Also insulin resistance. These days you go on social media, all the new fitness enthusiasts, they talk about insulin, but insulin resistance is just one of the thing that will cause the metabolic disorders, but the main hormone that regulates the metabolism is thyroid. If you look at any chart in your Guyton or anything where we talk about normal physiology, and I think there's a chart in Guyton, or there's one good book, I'll check the chart, I'll give it to you. There they have written in one line all the functions of all the hormones. There you will see the thyroid specifically, they only mention one good function, that is metabolism. Okay? But insulin resistance is just one of the reasons of this, but it is not the hormone that do. Insulin is all about regulating your blood sugar levels. Okay, na? And I'm repeating this part over here, I'm stressing it because when anything comes in your exam, you're talking about metabolism, a question. In the answers, the students write the stories sometimes when they don't know, and they induce insulin instead of thyroid. You better write thyroid, at least one line will be correct, rather than writing insulin. So hypermetabolic state, it is induced, just write down, it is induced by excess thyroid hormone and also overactivity of sympathetic nervous system, which is due to increase in beta adrenergic tone. So first line, there is excess, there is hypermetabolic state. Now when there is hypermetabolic state, it will lead to increase in BMR, which is our second clinical feature. Okay, write on second clinical feature, write on increased BMR. The clinical signs of increased BMR in a hyperthyroid patient are as follows. First, write down skin. Skin is relatively softer, warm, and flushed due to vasodilatation. Second, there is heat intolerance. Second in this only, in increased BMR only. Second is heat intolerance and increase in sweating. And third one is weight loss despite increase in appetite. Put a hyphen and write down. This is due to catabolic effect of excessive thyroid hormone. Next point is cardiac manifestation. Third point. Cardiac manifestation. Now there's an increase in beta adrenergic tone. There is a hypermetabolic state. In the first line, we have read these two things. So that means there will be some form of hyperactivity only. So the symptoms will be tachycardia. Okay, first write down, you'll write, just write down increased cardiac contractility and cardiac output in response to increased peripheral oxygen requirement leads to several cardiac manifestations such as tachycardia, palpitations, cardiomegaly, and arrhythmias. Now next is about, we'll discuss about the overactivity. These what we have discussed, three were about the hypermetabolic state. Next one we'll discuss about the overactivity of sympathetic nervous system. This leads to tremors, tremors, anxiety, insomnia, Then there's also one feature in this only, just write down one more feature. There is something called as thyroid myopathy. Thyroid myopathy, in which there is weakness and decrease in muscle mass. Now this decrease in muscle mass is due to both because of the catabolic effect and also because of the overactivity of sympathetic nervous system. The next is in the same one, gastrointestinal symptoms. Gastrointestinal symptoms, where we have hypermotility, diarrhea, and malabsorption. Hypermotility, diarrhea, and malabsorption. Now next we come to the ocular changes. The changes in the skin and the eye, whatever happens because of the thyroid, apart from their weight change, will be the most common symptoms given to you in the history, because these are more prominent, easy to look at, easy to explain. Because if somebody write in the history about palpitations, tachycardia in the exams, then your mind will go into the cardiac disorders. So examiner also, they give you the history that has got some very specific words that will be related only to those particular diseases. Now they talk about lid lag, they talk about exophthalmos. There's hardly anything else in your syllabus that will talk about it. Same way with the gastrointestinal symptom, you have written here malabsorption, you have got malabsorption syndrome. And the similar symptoms also come into the, when we'll read about the complications of diabetes mellitus. There also you get these same symptoms. So you can underline this symptom, because whenever a case study is going to come, one is the, you can write it in the rough, these things, that ocular symptom or the skin manifestations are something that are likely to be asked in a history in the examination. But you have to memorize all of the symptoms just in case they ask about the clinical features of hyperthyroidism. But to rule out other diseases, these are the two things that will be asked. If hyperthyroidism clicks your mind, you have to correlate with these. Okay. In ocular changes, write down, there is a wide staring gaze and lid lag because of sympathetic overstimulation of superior tarsal muscle. There is, in the next line, I don't know, the ocular changes. The true thyroid ophthalmopathy, is more pronounced in Graves' disease, where there is proptosis, exophthalmos. All right. Next feature is about the skeletal system. What happens in the skeletal system is there is increased bone resorption, which leads to increase in porosity of cortical bones, leading to osteoporosis and increased risk of fractures. Okay, these are the basic clinical symptoms that you will get, and just remember ocular changes, skin changes will be given to you when they are talking about hyperthyroidism. Next we'll discuss about Graves' disease. It is an important topic. They can ask you separately about it as a part of hyperthyroidism or when you're talking about the antibodies. Okay. How common do you think is Graves' disease? Have you seen very commonly patients with Graves' disease? Then why it is so important? You have heard about it. How common? It is actually very common. It is not uncommon. But as I've said, these symptoms, they take a little time. By the time they come, because of the advancement in the diagnostics, you're able to diagnose a patient and they are well treated in time, most of them, apart from the people who are living in villages or anything. And also after the induction, this iodine, iodine metabolism has been regulated by adequate salt intake, what type of salt intake you have to take. Apart from that, the Graves' disease has somewhat, it's not very common because it takes a little time. Okay. What about the autoimmune thyroid? We have discussed about Hashimoto's last time, and there are other thyroid diseases. This time or in the coming few years, if any one of you have to give it next year, the thyroid diseases have become very common, the autoimmune one, after COVID. So there can also be a history related to it. That after you heard about in the news that after COVID, the patients are complaining of weight gain, the patients are complaining of these. If gone through the articles, you will see that there was something called as thyroiditis, which was happening commonly, but it was not Graves. But the patients who were already prone to autoimmune, they have a family history, just that the autoimmune disease was not pronounced, they started having autoimmune disorders. And the Graves' disease is a little bit more common these days, just because of everybody has got a one dose of COVID, even if they deny, they have got it. So everybody is also getting some after effects. Not everybody, most of them are getting it in some form. And Graves' disease is also an autoimmune disorder. Now what happens in Graves' disease, there is increased in thyroid hormone production. When we talk about autoimmune, we think that there is going to be some destruction. So how, where there is a destruction, there is also increase in hormone production. How is that possible? If you don't treat it, it is going to continue. There is some destruction happening and also some hormone is being produced. How could that be possible?
Because the antibodies TSH receptor and so it is.
How are they stimulating?
Sensitivity.
But I'm talking about destruction. It is an autoimmune disorder. What do you understand by autoimmunity? It might be you are right partially. What you have said is, if you write it in the exam, you might get marks. But to understand how it is happening, You're right, TSH in stimulating antibodies, but do they also destruct these antibodies?
Ultimately, it will lead to hypothyroidism.
That is in thyroiditis. What you are talking about is decoherence thyroiditis. In Graves' disease, it's not ultimately, but sometimes the antibodies might destroy it. So in Graves' disease, there are antibodies, TSH receptor antibodies. In 90% of the patient, it will be stimulating. In 10%, it will be inhibitory. So not all Graves' disease will cause hyperthyroidism. Some will also cause hypo, but that is from the beginning. It is not what you are talking about thyroiditis. That is the next topic we'll discuss. That is thyroiditis, that hormones will deplete and ultimately there will be hypothyroidism. That is different. Okay, that is not this one. There also you may get antibodies because there is a disease, but that is not labeled as Graves' disease. To label it as Graves' disease, there is a specific diagnostic criteria. If you are getting that, we'll call it a Graves' disease, just not because we have found the antibodies. Okay, and the reason is we don't rely on the antibody because the antibody test we have so far is not ultra sensitive or anything. Sometimes the other circulating antibodies also might mimic like that. So there's a diagnostic criteria. Now what happens is somebody said mimic TSH, negative feedback is inhibited. Okay, so what happens is there are TSH receptor antibodies and there are TSH receptors in the thyroid hormone. So in the thyroid hormone, when the TSH is released, we are talking about normal physiological state, it comes and binds to the receptor and it will lead to the production of thyroid hormone. In the TSH, it does not increase the sensitivity, it mimics as TSH. So TSH levels are normal, but it mimics as TSH and it increases the production of thyroid hormone. Eventually, there's a negative feedback. The TSH will stop releasing. That is why we get low TSH, but we still get thyroid hormones because these antibodies, they are mimicking as TSH. And there is no other role of TSH otherwise. It is only about on the thyroid hormone itself. So whatever thyroid gland itself, so whatever changes happen, it happens there only. Okay, it is the antibodies, they just mimic as it, they just pose as TSH. They do not increase the sensitivity, nothing. Might be to some extent, but that is not the main feature, right? And due to that, there are the more pronounced clinical features are there because the cases sometimes they go undiagnosed. And why do they go undiagnosed? Because most of the physician, they rely on this TSH test. So initially TSH might not deplete immediately. It might take some time. Say a patient goes, okay, I'm having hot flushes. Mostly the disease happens in female. How it is misdiagnosed? They look into the age, it is around 40s. They start considering as a menopausal symptom, early menopausal symptom is setting in. So these kind of misdiagnoses, they happen. And this, when a history comes on hot flushes, menopause is part of your syllabus. There also you can write down this as your differentials. Whatever I tell these points, write it somewhere in your notebook about the differential, because when you're reading the notes, at least you will be able to keep it in your mind. You listen here, you'll say, yeah, this is obvious, but then you'll forget. Okay. Okay. Now in Graves' disease, there is hyperthyroidism and there will be eventually enlargement of the thyroid gland. There is hyperactivity, the follicles, because TSH receptor, it is binding to it. There will be hyperplasia of the follicles, everything, and eventually there will be diffuse enlargement. Second common symptom is of ophthalmopathy. I'm talking about the diagnostic criteria. There will be ophthalmopathy of Graves' disease. And the third one is the dermopathy. So when these three things are present, we consider it clinically as Graves' disease. Okay. What are the three symptoms? I'll repeat it again. Diffuse enlargement of the thyroid gland, ophthalmopathy, and dermopathy. I'll dictate it, no need to write down. Okay. This is the clinical triad of Graves' disease. We have discussed about the antibodies, the mechanism of this. How do we treat Graves' disease? How do we treat it? We cannot take out antibodies. So either we neutralize the antibodies, there is some way to do that, or we stop the production of thyroid hormone from the gland itself. So how can we do that? These are either we use drugs or we use the surgery. That is, we'll do the thyroidectomy, partial or complete, depending on the situation. And other thing is radioactive iodine. Now the treatment is divided into two parts. One is those who are below 40 years, those who are above 40 years. Those are the division of it, and that is how we take it. And the drugs commonly used are carbimazole and propylthiouracil. These are the two drugs, and if possible, remember the dosage also, because for carbimazole is 40 to 60, the other one be like 400 to 600. So just a difference of 10. If you can remember, not all the doses you have to remember, just I'll make you remember the ones that are easy to remember, so that you write at least a few doses in the exams, and examiner will, I just hope, okay, he'll be like, okay, you know a few, that's a plus point. Okay, the doses of important drugs also we will remember. Something very important, say we are talking about myocardial infarction, what dose of aspirin, dispirin you have to give, those things will remember, others you can skip. Okay, anything else, any questions in Graves' disease? Then we'll start with the notes. No, okay, we'll discuss thyroiditis also, and then we'll take the notes. In thyroiditis, this is not a part of your syllabus, but since most of the patient, as I was discussing after COVID, are also getting thyroiditis, so it might come as an out of syllabus question, because it is not completely out of syllabus also. Thyroid is part of your syllabus. So what happens with thyroiditis? Thyroiditis is commonly seen after Coxsackie virus, mumps, adenoviruses, and now even after coronavirus. In that, there is some destruction of the thyroid gland. It is more like injury. You fell somewhere, you get injured. So when you get injured, there is oozing out of the material, normal, serum is coming out, blood is coming out, these things are coming out. For some time it will happen. Then it will stop. Then the skin becomes very dry in that area. This scab is formed and it is all dry thing. And after that, normal skin resumes. If you remember this, you will be able to remember the graph of thyroid gland, how it happens in thyroiditis. Okay, what happens? I'll just draw it like this. And we are dividing it here into months, because it is a process that takes like almost 6 months. Okay, so here there is injury has taken place. There is destruction of thyroid gland, and it is a significant destruction. What happens when the body is making antibodies against the virus that has come? Those circulating antibodies, they cross react here. Those details you do not need to remember, all the pathophysiology, and they destruct the thyroid gland. And here we are taking about the levels of thyroid hormones which are circulating. Now there is a state of hyperthyroidism. It will start with hyperthyroidism after being normal, and it will continue for few months. Okay, so there are all the symptoms of hyperthyroidism. We say कि we call आपको weakness हो गई है virus के बाद, बीमार हुए, weakness हो गई. That is not weakness. Sometimes it is related to this only. So there is a state of hyperthyroidism. Then eventually after say 2-3 months, the patient becomes hypothyroid. Okay, because all the hormone that was stored in the thyroid gland, it is being released over here. Okay, so this is the time of, you can write down also if you want to in your notebook, this is the time of release of the stored thyroid hormones. At that time it is releasing, and in the beginning it is too much. You are being injured, the blood oozing out is a lot. With time it will decrease. So after that it is depleting, and then ultimately you reach a stage of hypothyroidism, and hypothyroidism is sometimes also very pronounced. So that happens. That also again continues for some time, and then there is a recovery. The normal follicles, they recover, and the patient gets into a euthyroid state. Okay, this is this. And after depletion, this is basically when the thyroid is getting repaired. This is like the regeneration time of the thyroid, and after that we reach to the euthyroid state. This is the graph about thyroiditis. If thyroiditis is asked, this is given in the books also. Try to make this graph. I'll again explain. Here we are taking time, and this is in months. Okay. Here we are taking the hormone levels. So there is injury to the thyroid gland, there is a release of hormones, it will deplete over the period of few months, then there will be hypothyroid state, and then there will be euthyroid state, and this will take around 6 months. So say the patient has come to you here with the hyperthyroid state. How will you diagnose the patient here that it is a case of thyroiditis, it is not a case of other causes of hyperthyroidism? Unnecessary FNAC, or you ask patient go for ultrasonography, that is like a waste of time, resources, and discomfort to patient. You'll get the test and you see TSH, T3, T4, these things. What next investigation you'll go for? Anyone from online classes?
History.
You can take history, very good. What else?
Repeat the test after 1 month.
1 month, and what will you do in between? Say it's a Graves' disease, it might advance very soon. The exophthalmos, you cannot take it back, no? So what next you will do? There is a hyperthyroid state, that might be any kind of adenoma, any kind of differentiated carcinoma. You cannot leave it for 1 month. You leave it for 1 month when you are a bit sure that it is a case of thyroiditis. But before that, what? We have done thyroid hormones, we will take history. Yes, Sushmita, you're right, we'll go for the antibody panel. Okay? All the antibodies, if they're negative, we'll rule out the autoimmune disorders simply. We'll ask for if there's any discomfort. History is matching with the negative antibody panel. It can be a case of thyroiditis. We'll ask them to, but because this is going to take a little bit of time. So it is not that it is going to get better very soon. But you are going to observe patient after 1 month. Initially, it will be very high catabolic state, loss of weight and everything. Slowly, the weight symptoms somewhere around here only, they will start getting normal. Because this is somewhat of a euthyroid state only before the patient goes into a hypothyroid state. After that, they'll go into hypo and then this. Okay? A case study is less likely to come in this, but you should know just in case. If a case of something like this comes in the exam, it is very less likely that many students will be answering this. So this is why I'm teaching this to you, just for an extra bonus mark, hoping you'll get it. Okay. All right, write down about the Graves' disease now. Graves' disease is an autoimmune thyroid disorder. Autoimmune thyroid disorder that is characterized by the clinical triad of hyperthyroidism, ophthalmopathy, and dermopathy. Most commonly, women of 30 to 50 years of age. Most commonly, the women of 30 to 50 years of age are affected. Next, write down. Next, get the heading pathophysiology. Pathophysiology. The thyrotoxicosis here results from production of IgG antibodies which are directed against the TSH receptor. These antibodies can stimulate or block the receptor activity or block the receptor activity. In 90% of the cases, the receptors stimulate, sorry, not the receptor, in 90% of the cases, the antibodies stimulate the receptor, which leads to proliferation of follicular cells, in the just bracket write down diffuse swelling, that is how you get the goiter of Graves' disease, and overproduction of thyroid hormone. Try on the next line. The TSH receptor antibodies binds to the TSH receptor, and mimics its actions. With its you can write on TSH in case you get confused, and mimics its actions, which is increasing the release of thyroid hormone. These antibodies can be detected in about 80 to 90% of Graves' disease patients. Okay. The clinical features will be same that we have discussed with the hyperthyroid set. Just you have to remember there is a clinical triad when we clinically diagnose a patient as of Graves' disease. Right. Rest of the symptoms will be same of the thyrotoxicosis that we have written. Next, write down about diagnosis. The diagnosis is established on the basis of classical clinical triad, and other features of hyperthyroid state. Then write down on diagnosis only. Next line. The free and total thyroid hormones will be increased, TSH will be decreased, next is thyroid TSH receptor antibodies or thyroid receptor antibodies, TRAB, which we commonly called as, will be positive. The ultrasonography and FNAC, they are not very effective in this. So when you are approaching a case of Graves' disease, you can simply skip it also. What else can be done? It is not routinely done, but what else can be done? You have taken the notes last time on thyroid function tests. You have got in syllabus thyroid function test, liver function test, kidney function test. In the first class, most likely I'll be dictating you the function test only. In the next class, it should be on your tips. Okay, you were saying scintigraphy. Radioactive iodine uptake is obsolete now. नहीं कर रहे हैं because it uses the radioactive material. Scintigraphy. Okay, technetium per technate scintigraphy will be done, and it will show what kind of uptake it will show and why. And why? तुम बताओ. You give answers, lot of he knows. बताओ. Why will it give diffuse? Just think about it. It will give a diffuse uptake. Why will it give a diffuse uptake? Last time we read about the scintigraphy that all the follicles that are active, those are active, those are functioning, those are taking up the hormones, they will take up the technetium. So here there is hyperactivity of thyroid follicles, there is hyperplasia, so it will show diffuse uptake. Whole of the thyroid organ is involved. Okay, we'll discuss about it. आज पढ़ेंगे उसके बारे में. So there is a diffuse uptake. Okay. Next item about the treatment. In this item, the symptoms of thyrotoxicosis respond to beta blockade, respond to beta blockade. In the next line, for patients under 40 years of age, carbimazole and propyl thiouracil can be given. Now in this only write down, okay, write down the doses also in the bracket if you want. This is 40 to 60 milligram per day. This is 400 to 600. The patient shows improvement in 2 weeks. The patient shows improvement in 2 weeks, and the patient will reach euthyroid state. The patient will reach euthyroid state in 3 to 4 weeks, after which the dose can be titrated. Dose can be titrated to maintain the hormones within reference range. Next item, the mechanism of action of these drugs. These drugs reduce the synthesis of new thyroid hormones. Reduce the synthesis of new thyroid hormones by inhibiting iodination of tyrosine. By inhibiting iodination of tyrosine. How many of you remember how is the thyroid hormone made within the glands? Yeah, oh, I thought you were raising the hand. Sorry. Tyrosine, they combines with iodine. So here it prevents the iodination of these drugs. They prevent the iodination of tyrosine. This is the mechanism of action. Okay. Next, write down about the contraindications. The drugs are contraindicated during lactation and also in the patients with hepatotoxicity and history of hypersensitivity rashes. If they already have a history of any previous fixed dose eruption, you should avoid the drugs. Okay, now next part of the treatment is surgery. Next is second. We have discussed about drug.
Propyl uracil is indicated during pregnancy and lactation.
Yes, not both the drugs. Carbimazole is contraindicated. I'm sorry. This propyl uracil you can give. Okay. Next part of the treatment is thyroid surgery. Then the contraindications. There you have to write down carbimazole is contraindicated. Okay, in lactation, but both of the drugs otherwise they are contraindicated when the hepatotoxicity and hypersensitivity rash. Next, write down surgery. A subtotal thyroidectomy. A subtotal thyroidectomy can be performed in cases of relapse. Can be performed in cases of relapse. Full stop. Some portion of thyroid gland is left behind, or use the word is left in situ, with the aim of rendering the patient euthyroid post-operatively. Contraindications for this surgery are any previous thyroid surgery, or the patient is dependent on his voice, might be singer, teacher, hawker. What can be the complications of this surgery? Hemorrhage से पहले injury to the recurrent laryngeal, that is why we are writing here it as a contraindication to those people, and it might lead the patient to hypothyroidism state. Because the surgeon he's going to left the thyroid with some estimation. It might be less, it might not be enough, so leaving the patient to hypothyroidism. So that way it becomes little difficult to titrate the dose. In case you know that the patient will be hypothyroid from now on, you have removed the whole of the gland, you know what dose to give. There is actually a fixed dose, and based vary from patient to patient, so that becomes easy. But right now here some thyroid hormone will be released, some not. That is why hypothyroidism is one of the complications. It is a bit difficult to manage for this reason. So these are the two complications. Now next treatment choice is radioactive iodine. Radioactive iodine is commonly employed as a treatment of choice. You can write down radioactive iodine like this also. 131. As a treatment of choice in patients above 40 years of age, where the iodine is administered orally as a single dose and the dose, if you can remember, is 10 microcurie. If you want to remember, it's okay. If you don't want to, also it's fine. In case thyrotoxicosis persists, after 6 months, then a second dose can also be given. Right, on the contraindications: pregnancy, or in case the patient is planning the pregnancy in next few months. Then active graves of ophthalmopathy. It is because this actually contraindication is a bit controversial, because in some patient it increases the ophthalmopathy. So to counter that, usually prednisolone is given for some time, but there is no basic mechanism, it is not clear, but it happens, so it is kind of contraindicated. There are other treatments, you prefer that. Okay. So now in a case study, you get ophthalmopathy, patient is above 40 years of age. So your first line of treatment will be, I said patient has ophthalmopathy and is above 40 years of age, Graves' disease hai. So you can start with the surgery in your flow chart. Surgery, then drugs, then these things. That is how you start. Okay. Last you can write radioactive iodine because it is a controversial contraindication, but then it does not become your first choice. Okay. Just change it a little bit. These things you'll practice with the flowcharts. I'm going to give you different scenarios, and in those scenarios, when you are going to make the flowcharts, you will understand how to proceed. Next, we will make a flowchart first of all for the approach to a thyroid disease. Sorry, hyperthyroidism. Last we have made about the hypothyroidism. This time we'll make for hyperthyroidism. So free T3 and T4 are increased and TSH is decreased. Okay. How will you start with it? What is the next thing you'll do? Any case study, any flowchart, anything happen, any disease you're talking about, what is the first thing? History and the clinical features. Do not forget that the patient we are discussing here is a human being. A clinical examination is mandatory, right? So anything happens, we start with the history and the clinical findings. The clinical findings say it will give you a hint about, is it a patient of, can it be a patient of Graves' disease? Is it a multinodular gout where sometimes there are nodules, there is a hard nodule? You start thinking about adenomas and carcinomas. That is why the clinical findings and history is important. Right? Now, based on that, you will just give me one. Okay, so based on the clinical findings, we'll then proceed with our differentials. So what all differentials we have discussed? Or okay, thyroiditis. So basically any recent illness, you'll talk about the patient. Okay, we'll discuss any recent illness. Then we already have today Graves' disease, and there are also certain hyperthyroidism states which are of non-grave. We usually write it as non-Graves illnesses. Okay. Now, what will be the finding in Graves? You can write down in your flowchart the findings. There will be a diffuse swelling. Okay, I forgot to discuss about the bruit. In Graves' disease, there is increased vascularity, and that is why when you hear it with the stethoscope, you get to hear the bruit, the sound. So in Graves' disease, you will get a swelling with bruit. Do not use shortcuts in your flowchart. I have the liberty, you do not. Okay, so there will be a diffuse swelling with bruit. Then what else in Graves? Have you got a clinical triad? Ophthalmopathy, dermopathy, this will be present. Then we come to the non-Graves illnesses. In the non-Graves illnesses, there might be a small swelling. Here you see the diffuse swelling of the thyroid. It is easy to make out it's a thyroid swelling. So when you have got a small swelling, what do you ask a patient? You ask a patient to drink something. The thyroid always moves with deglutition. So here also in the clinical examination, to check whether it is a thyroid swelling, and when that happens is if it is a solitary adenoma, okay, solitary nodule basically. That is, there is one nodule, you are not able to make out it's a lymph node, it's some other swelling. In those cases, there is multinodular goiter. There can be a carcinoma swelling, there can be an adenoma. Okay, these are the non-Graves illnesses. Now here our next line of investigation will be, we'll ask the patient for the antibodies. We'll check the antibodies. Okay. In the non-Graves illnesses also will get ruled out by the antibodies, but usually we do not go for it. What do we go here in non-Graves? You know, there is a small swelling, it feels like thyroid only, it's hard, it might not be hard, it's cystic. What next investigation comes here? First ultrasound, then FNAC. Okay? So first we go for the ultrasonography here. Then you can just put a hyphen and write down here FNAC. And you can also do some other investigation. What about the other investigations? Any CT scan, anything else? Because radioactive we'll discuss here. I've left that part. So any other investigation, it is a carcinoma, it feels like carcinoma, you can go for the CT scan to look for mets or any other investigation. So then based on your history, basically I'm leaving this here, FNAC and other investigation based on your history. And here after ultrasonography, because there is adenoma, there's multinodular goiter, now you want to know it's a hot nodule or it's a cold nodule. And also for the Graves' disease, we'll go for the radioactive scan. Okay, radioiodine uptake or the technetium scan or the radioactive iodine uptake. Now the flowchart doesn't end here. Now we will see at the findings of the radioactive uptake. Okay. So what will be the findings of the radioiodine active uptake? When you will get the note on scintigraphy, there also you have to make this diagram, what we are going to make now. And in all the approach of to cases of the multinodular goiter, solitary adenoma, Graves' disease, everywhere you have to make the diagram that we'll make now. Okay. There are few things that are commonly diagnosed with this. Just make 4-5 thyroid glands. Now you have given the patient the technetium pateknate, and we are waiting for the results. In case what does this looks like? The first one.
diffuse pattern.
What does this looks like?
It is increase of the
So
concentration.
isn't this like more diffuse pattern? That is the normal uptake. Okay, follicles जहाँ जहाँ है, ठीक है ना, वहाँ पर वो. This is the normal uptake. Say normally also, because this is something that a thyroid follicles, they are uptaking it wherever there is thyroid hormone. So normally also in thyroid gland there will be hormone, right? So this is the normal uptake here, and I'll tell you the conditions where this will be significant. And this is a diffuse uptake that we were talking about Graves' disease. In Graves' disease, whole of the thyroid hormone is hyperactive. So this state shows hyperactivity. Most commonly in the Graves' disease. Yes, Ankit, you're right. First is normal, second is diffuse, third is solitary. This one is the solitary nodule. This can be adenoma, it can also be carcinoma, it can be anything, it can be a simple cyst, anything. So it is a solitary nodule. And what is this last one? This is multinodular goiter. Now if you notice one small thing, I have made this multinodular goiter in both the lobes. Okay. The multinodular, usually they are in both the lobes, they can be in one lobe also, but the multicentricity, when we are clinically examining the patient, this becomes important. This is a multinodular goiter. It is, if the swelling is in both the nodes. See, there can be carcinoma in one lobe, it rarely goes into the second lobe till the time it is diagnosed. And in the same lobe, it might show present as a two swelling, but it will be in the same lobes, on the same side, you can examine. But if it is a multinodular, you will see the multicentricity. So in the history, if in any detailed examination is given, a multicentricity is most likely a multinodular goiter. And also multinodular goiters harbor follicular carcinomas, we'll discuss today. So that is why I've made it in both the lobes. Okay. Now this has happened. So when will you see this condition? If there is this is not a normal thyroid gland, this is normal uptake of iodine. Just write a normal uptake, not a normal gland. So when do you see the normal uptake? कब दिखेगा? Is there any condition that we have discussed? सारे warm है. These are all warm. Cold means के it is not taking up. Warm means uptake. All are warm. So what do you mean by that? It is in thyroiditis that we just discussed to rule out, because hyperthyroid state है patient का. If just in case any circulating antibodies are mimicking like Graves, but you clinically feel it is not Graves, so that will be the uptake. There will not be a diffuse uptake in cases of thyroiditis. Okay. Then there are other disorders also of thyroid, simple thyroid inflammation, thyroid infections. There are other, so there also will have a normal uptake. Hyperactivity, hyperuptake, Graves disease, solitary adenoma, and MNG. And these are all warm nodules. A cold nodule means, last time also said, a cold-hearted person who doesn't take up your feelings, that is a cold nodule. So these are cold areas. Okay? Just in case if you want to talk. Say there is a carcinoma, and that carcinoma is not functioning in any normal way. It is not it is an anaplastic carcinoma here, and you are thinking it might be a solitary adenoma or anything. There also you will find out like this, and say in the center there is a carcinoma, you will just find out like, but it is not diagnostic. It might be just a cyst also, anything. So anything that doesn't take up will be an empty area. That is a cold nodule. Just remember with this analogy, cold and hot, a cold-hearted person doesn't take up your feeling, a warm-hearted person only will. Okay, na? So these are all the cold nodules. Any confusion in this to anybody? This you have to make in scintigraphy. You have to make this if you get a note. In all the approach to hyperthyroid cases, in Graves disease when it is asked, just make this. That on scintigraphy, just make it on the side. This will be seen. No need to make the others. You can make this normal uptake and diffuse uptake. That's it. Or simple diffuse uptake. Any doubts? Okay. Online students also look fine. Okay. Last time I have given you one exercise. I have given you one assignment. Let me go to the assignment. So now we have completed with thyroid. Okay, na? And now we'll discuss about the assignment. You all can go back to those who have not noted the assignment. I'll again repeat it side by side and we'll see. Should I clean it? Everybody has got it? Right? It is given in your books also. All right. Coming to the assignment. What was the first interpretation? TSH. What was the first one? Okay, I'll start with the online students. Ankit Bajaj. Ankit, the first interpretation was that TSH is undetectable and T4 is raised and T3 is raised. What is the diagnosis? You can write down the answer. I'll ask everybody. सबका नंबर आएगा. Okay. In case you don't know, just pass the question. We'll discuss it. Hyperthyroidism primary. It's right. It is primary thyrotoxicosis. Okay. Second interpretation was, I'll go with the next person. Arnav. Second interpretation was that TSH was undetectable, T4 is normal, and T3 is raised. What is the diagnosis? In case you don't know, just write down pass, and if you know the answer, just write the answer. Hema, you will have the next one. I'll just tell you the question. The third one is that TSH is undetectable, T4 is normal, and T3 is normal. I'm still waiting for Anna's answer. Are you all able to do it? नहीं पिया कोई बात नहीं, but were you all able to, was it a difficult one or it was okay? Somewhat difficult. We'll discuss. Okay, I'm not sure if Arnav knows the answer. For the second one, where the TSH is undetectable and T4 is normal and T3 is raised, it is primary T3 thyrotoxicosis. Today we have discussed that there can be hyperthyroidism where T3 and T4 both will be raised. There can be a T3 thyrotoxicosis. So that is primary T3 thyrotoxicosis. Third one, Hema, I'm waiting for your answer. Okay, don't know, I'll leave it. In third one, we have TSH is undetectable and T4 is normal and T3 is normal. What is that? Yes, it is subclinical hyperthyroidism. In subclinical hyper or hypothyroidism, the T3 and T4 levels will be normal, but TSH will show you the picture. So when TSH here is undetectable or it is decreased, so that tells you the state that this is a hyperthyroid state. But if the thyroid hormones are normal, we call it as subclinical. Okay, next I come to Rakesh. Rakesh, next interpretation was TSH is undetectable or low and T4 is raised and T3 is low or normal. This was difficult. Okay. Primary T4 thyrotoxicosis. No, there is nothing like primary T4 thyrotoxicosis. Either it is only thyrotoxicosis because, see, normally also in hyperthyroidism, in the periphery mainly the T3 gets converted. So sometimes the T3 levels in hyperthyroid state are not high, but that is normal. But there is only T3 thyrotoxicosis when T4 is normal and T3 is raised. That happens in some conditions. Those are not a part of your syllabus, so we're not going in detail. But here, which one was it? Okay, here we are discussing that this is a hyperthyroid state where T4 is bit raised and T3 is low or normal. That means lower side means ki it is not being released from the gland, but there is an external source of T4, that is the factious. It can be due to drugs or any non-thyroid illness that where the results are mimicking like a T4. Okay, but at that you leave factious is correct answer. Okay, next one was next I come to Sushmita Singh. The TSH is undetectable and T4 and T3 are low. So basically all three are low. यही था ना? Secondary hypo, okay, you're right, it is secondary hypothyroidism or it can be transient thyroiditis also in evolution, okay, or it is secondary hypothyroidism. Okay, next is Hridi. Next interpretation is TSH is normal and T4 is low and T3 is low. I think she knows. Okay, here the low can be also be in the lower range of the normal part. This is also again secondary hypothyroidism. Okay. Okay, next one I'll ask here. We'll tell. Next interpretation was mildly elevated TSH. This I've given. Actually, I skipped 1, 2 interpretations. I've given this one. Okay, mildly elevated TSH, low T4 and low T3. Primary hypothyroidism or secondary also. It can be both because it is mildly elevated TSH. Now, elevated TSH beyond 20 milliunits and low T4 and low T3. आप बताओ आपका नाम क्या है? हाँ, यामिनी. या टेल मी. Elevated TSH, hypo, which hypo? Primary hypothyroidism. Okay. Even if you skip hypo, but write on the subclinical, you write on subclinical, primary, secondary, even if you miss out. This is only just to make you understand if there's a case study, right? Okay, then we have written about the, no, I have skipped this part. I have not given the reference range of TSH 20 to 500, right? In your this, okay. Come to the next one is TSH is elevated, T4 is elevated, and T3 is elevated. This I've given. This is the last one, I think. Okay. Yeah, tell me. Hmm?
Secondary hyperthyroidism.
Secondary thyrotoxicosis or pituitary adenoma, it can be, but not very common. What else? Because that usually can cause hypo also. What else?
Inappropriate loading dose.
Yeah, in the high T4 dose. Okay, factious and secondary thyrotoxicosis. Okay, so with this we finish the thyroid as a topic. Anatomy, I have asked you all to read and come with the doubts and submit your assignments. 2 diagrams that I've told you to make. A few of you have mailed the assignments and I've replied already to everyone. Those I've received till today, 3 p.m. Okay. Rest of you leave your sheets here. I'll correct them. And we have discussed it in anatomy. Then you have also discussed the thyroid function test in biochemistry. We have finished it in medicine, hyper and hypo, and we have also finished it in surgery. Okay, so at least in your syllabus 4-5 topics are over, kind of. Huh? What? Carcinomas. Oh, sorry, I forgot. Carcinomas we have to discuss yet. Okay, we'll discuss. It's in today only. I'm sorry. So next we'll discuss the carcinomas and then we'll say it is over. Okay. All right. So far in the carcinomas, UPSC has asked about the papillary carcinoma most frequently, and they have asked about the follicular carcinomas very frequently. They have asked you about the approach and everything. Then they have given I can say basic and simple case studies. Now the problem that has arisen recently is about the treatment part. So today what we are going to discuss in the treatment part, it might not be the same as it is given in your book, but it is the recent advances. All right, it is being followed now, and that is what you will discuss. The recent publications, all of them have it, but in case there is any discrepancy from their older edition, it's okay. Just be safe. What we'll discuss today will be fine. Okay. All right. We'll start with thyroid carcinomas. First of all, we'll come with the classification. So the classification of thyroid carcinoma that is accepted is only one classification which is widely accepted, and it is given by Dunhill. Okay, you can write it down just in case they say classify or how will you elaborate. Even if a simple 2-mark question come that what are the thyroid carcinomas, sometimes with a 10 marks question they gave a small question also. So in those cases the classification it is a Dunhill classification. It is not given in your Manipal. I think it is given in Bailey and Love, but this is the classification which is followed. Okay. So how does the Dunhill classify? It basically looks like a histological classification, but the reason of classifying based it on the cells is because of the tumor markers that we correlate with. Okay, na? Because with the medullary carcinoma, the markers are different, the treatment choice is different, everything is different. So that is why they have they have classified it like this. So we have got benign, we have got malignant, and here we will write about the cell of origin, from where this carcinoma is arising. So first cell of origin is follicular cells. So the follicular cells of thyroid will give rise to follicular adenoma. What else? In malignant, what will be the malignant one? Follicular carcinoma. Okay, which is the most common one first? Arising from the follicular epithelium, the most common carcinoma. That is why we have classified it like this, because you know the name, but you're not sure from where it is arising. It is papillary carcinoma. That also arises from the follicular cells only. So first we'll write the most common one, that is papillary. Then in the same section, we will write follicular carcinoma and also anaplastic. They are also mostly the follicular origin. They can be anything else also, because we are not able to classify, but mostly they are follicular. Next comes the parafollicular cells. In parafollicular cells, we have medullary carcinomas, then you also have lymphoid cells. Lymphoid cells are not part of thyroid, but in cases of thyroiditis, sometimes there can be some mutations that can proceed to lymphomas. So lymphoid will cause lymphomas. Then you can have secondaries, you can write down. They can be from anywhere, the METs, okay? Local infiltration or the METs. All right, now the follicular cells that we have discussed, these carcinomas, especially these two, anaplastic I'm leaving, okay? This is not the part of classification, what I'm going to tell. Classification bas itna hi hai. This is for our understanding and for us to remember. These two carcinomas are usually considered as the differentiated carcinomas. Okay? The differentiated one, they can be well, moderate or poorly differentiated. The treatment plan also more or less remains the same, and the staging is also same. And also we use here as thyroglobulin as its marker if we have to assess post treatment response. Okay? In medullary carcinomas, staging is similar, but treatment is little different. And also the medullary carcinoma, their markers are calcitonin and carcinoembryonic antigen. Apart from that, since it's a neuroendocrine tumor, serotonin can also be there, but these are the two most common ones. Okay. For the lymphomas, there are no markers, but just to diagnose lymphomas, we go for flow cytometry. We have the CD cluster designation cells, differentiation cells. Okay. We do the CD markers. Alright, so in case you are asked to enumerate the thyroid carcinomas, just write down the classification and also mention by Dunhill. Get good marks for this. Okay? Otherwise, just classify it like this. So, some of you must have learned today that the follicular carcinoma also give rise to the papillary carcinomas. That is why we use thyroglobulin only. Same marker is used. Okay, we'll start with the first carcinoma, which is papillary carcinoma thyroid. Now, the papillary carcinoma thyroid is the most common that arises from the follicular epithelium. It is most common, I'm not dictating, I'm speaking. It is most commonly seen in females of the age group 20 to 30 years. Okay? The interesting features, there are certain interesting features of papillary carcinoma, which we'll discuss, which are seen on FNAC and also on the histological examination. Okay. Apart from that, the most interesting clinical findings that happen to be are, that is occult carcinomas. They are most common with the papillary carcinoma and they're less common with the follicular one. If there is a history of follicular carcinoma, there might be a history of any cystic nodule, any multinodular goiter, because that is the setting. If you get a history that looks like a thyroid case study, and there can be an occult carcinoma with lymph node metastasis. What happens in papillary carcinoma is, occult carcinoma, or we call it as microcarcinoma, they are less than 1 centimeter in size, okay, and they readily metastasize to the regional lymph nodes despite having a smaller size. That is the feature of papillary carcinoma. So sometimes a patient will present to a young female with this age group presenting with the cervical lymph nodes, that is papillary carcinoma. And the another important feature is, just because there is a metastasis to regional lymph node, it does not change any prognostic. There is no prognostic significance. Otherwise, in all the carcinomas, wherever you will read about mets, that changes the staging, that changes the prognosis. But in papillary CA, it does not. Okay. These are the two important. This is just for your understanding of the case studies. We will write it also, but it is for that. Now, what are the features of papillary carcinoma? The interesting one, the FNAC features. Okay. There are certain, how will you start? You will not just haphazardly start. We know that it is arising from a particular cell, follicular cells. A cell has a nuclei and a cytoplasm. So there will be certain cytological features, the cytoplasmic and certain nuclear features. So write it in that order only. So first we have got the nuclear cytoplasmic feature that has got the pseudo inclusions. Okay, I'll dictate. Just wait. I'll draw it also. And then next feature you said about the orphan NEI. Basically, the nucleus, the chromatin, which is usually dense, it gets cleared up and goes into the periphery, giving it a cleared appearance. Okay, say this is the nucleus. Okay, normally it will have chromatin like this. Any nucleus, if you see, it is all covered and dense and dark, right? But in this case, the nucleus, it goes into the periphery, the chromatin, and there is a clearing. It only shows it like a very light purplish hue you can see. And then there are also, this is only nucleus, then there are also nucleoli, several nucleoli. Okay. So when these two nuclei are there, it gives characteristic cartoon appearance. Orphan NE was somewhere in 1960s, if you have seen right now also. These kind of spectacles are there and two eyes were seen like this. That is the orphan NE. Okay, that is how the name came here, the orphan NE nuclei. Okay, then the one part that I'm talking about, the pseudo inclusions. What happens is, say this is the cytoplasm. Inclusions means that some part of the cytoplasm or the nucleus, it invaginates into the other. Okay, the pseudo inclusion is because the cytoplasm is filled up. It is actually very a fat cell, you can call it, but it is not a fat cell per se. But so those cytoplasm which is extra, it goes and it is lying over the nucleus. But because the nucleus is very clear and almost transparent, it gives the appearance of inclusion. So that is why you use the term pseudo inclusion. It is not a true inclusion, right? So there's a pseudo inclusion. There are clearing of the nucleus. There are nucleoli. Okay. Then another interesting feature we have is the samoma bodies. Calcifications can be seen in any of the carcinomas. So just calcification or microcalcification is one of the feature, but not the diagnostic. And what I'm talking about are the diagnostic features here. Okay. So another is the samoma bodies. What are the samoma bodies? Samoma bodies are basically the papillae, that there's a papillae going, and papillae are like this. There are finger-like structure, and in between the papillae is a fibrovascular stalk. Basically it is fibrous and the vascular tissue, but these are the papillae, right? And this part of papillae, the top one, because this is attached to the base and the it gets the blood supply and everything, but as soon the papillae they start growing, the fibrovascular stalk it gets detached in this part, and this papillae, the upper part, it starts dying. So in the center of the papillae it starts getting calcified. Okay, now the calcific material start getting deposited and there are more papillae around it. It starts growing as a concentric circle like this, and this is what you call as samoma bodies. The normal calcifications that you see even on ultrasonography, that you are going to write that what type of calcification we are talking, those are just, you know, this is calcific deposit. Any dead any dead cell that is neoplastic can give microcalci. We read about it in breast, we read it here, that are the fast growing tumor. It is an indication ki cells are rapidly changing. Okay? But the samoma bodies are formed mostly in this, in the papillary. It can be anywhere in the body. Papillary carcinomas, they show the samoma bodies. Okay? So these are the samoma, because this is what I'm drawing a cut section. But if you see, look at the papillae, they are basically somewhat like leaf, like this like structure, and there is one more round structure coming. So the space here is usually round, so it starts growing like this. That is the reason. Okay? So these are the samoma bodies. Then that is all the features that we have. Okay? And also there can be, sometimes there can be grooving also in the cells. That is, it just looks like grooving. Okay? Grooving is nothing, just a fold in between, a line in between. Okay? These are the features. Why do you have to write about these features in your findings compulsorily in the papillary CA cases? Because sometimes there is a follicular variant of papillary carcinoma. It clinically looks like a follicular carcinoma. It, in all the ways, it behaves like a follicular adenoma or a carcinoma. But when you look into the slide, even in the CT and everywhere, you can get confused. These nuclear features are present, but it is present as an follicular carcinoma, the pattern. Okay, the papillae are not there, but the nuclear features are this. There you have to treat it as a papillary carcinoma. The prognosis changes. Okay, that is one important thing that changes. Then the metastasis, here it is lymph node, in that we'll study about the blood lymph hematogenous metastasis. But in follicular carcinoma, there is a lymphatic metastasis that changes the prognosis, but here it doesn't. So that is why when you are talking about papillary, you have to write about these features. Okay, if you get time, you draw it also, a small diagram. If you don't get time, it's okay. But these are the features you should remember. Okay. Then how do you diagnose? What investigations will you do in case of papillary carcinoma? How will you start? Patient has come. I give you a case study. A female 25 years of age is presenting to you with multiple lymph nodes in the neck, cervical lymph nodes only. And there is a small palpable swelling in the thyroid, along with little hoarseness and voice. Okay, how will you proceed with the case? Now I'm not mentioning anything about thyroid here. Okay, na? How will you proceed with the case? You might read the history and you know it's a case of papillary carcinoma, but how will you proceed? Directly FNAC? हिस्ट्री तो बता ही दिया मैंने, और तो क्या ही हिस्ट्री लोगे, और कुछ ऐसे क्लिनिकल फीचर्स होते ही नहीं है, मैंने सारा हिस्ट्री दे दिया है ना. This will be the history. What hints you are taking from history? Why you, because when you're writing in the exam, say you directly write down papillary carcinoma thyroid, okay, the examiner will say okay 1 marks for this, but you have to convince him also na ki why papillary, just because ki ratta mara hua hai nahi, but why. So the clinical features that point here are, there is a swelling in the thyroid region. Okay, the lymph nodes are palpable, right? Then there is hoarseness of voice. Hoarseness of voice is also one of the features of carcinoma. It is an advanced stage carcinoma, but it is also a feature of carcinoma with thyroid swelling. Okay, laryngeal tumors udhar bhi hum padhenge, but with this clinical picture, typical hoarseness of voice is a feature of carcinoma. So there you will say these are the points pointing towards your diagnosis. Okay, how will you examine next? What next? You don't go for FNACs directly. You first want to see what is there. You know, FNAC में क्या करते हैं? You poke a needle. So before poking a needle, at least you would like to see what is there. Curiosity में ही देख लोगे ना. ऐसा नहीं कि patient को मतलब you just have to poke it. It might be anything else also. So you first go for the ultrasonography. Then you will write down the features of ultrasonography. What all can you write in papillary carcinoma? Sometimes a good radiologist can even tell you that this is a case of papillae. The papillae can be seen. Okay? The papillae can be seen, and also microcalcifications, they can be seen. They will tell you about the calcifications and papillary lesion. Then the lymph nodes also. The lymph node morphology on ultrasonography will be similar to what is in the thyroid morphology, the swelling. There, because the mets have gone there, so it will also show microcalcification. Now, rarely there can be a picture where the thyroid gland shows microcalcification, but lymph node is not showing. And they can also even write you in the case study as a finding also. There the lymph nodes are reactive, host response. ठीक है, आपकी बॉडी में कुछ भी होता है, there is always a host response. There is a host response separate carcinoma also of breast that we'll study. So host response can also be there. In case it is given, so do not मतलब rule out papillary carcinoma कि वो नहीं है तो ये नहीं होगा. It is not the case. ठीक है. Then after that, once you know it, you are suspicious of a malignancy, it does look like a malignancy, what you will do, but you'll rarely see a radiologist writing malignancy on ultrasonography. Now the reason here is that sometimes the cystic changes, normal cystic changes also lead to this. Cystic changes is nothing. Cyst is just a pimple inside the body, kind of in a layman term, you know, that has got some water in it, dirty water. So that water might have got some debris, and that debris might calcify over the period of time. So those can also be one DDs of calcifications. So next we go for the FNAC. You do the FNAC of the patient and you look for the typical cytological features. There, that is the confirmation of your diagnosis. Now the patient is also complaining with the hoarseness of voice. The hoarseness of voice is a sign of advanced disease. That means some larynx is being involved behind, some other cartilage is being involved. So that is fine. But sometimes it is also because the tumor is pressing, and that is why. So usually advanced disease, usually, and rarely, if the patient is lucky, it is just nothing but just a tumor pressing on it. Okay? So because you have a doubt of METs also and advanced disease, you will go for a CT scan. Okay? PET scan is usually not done, but in some cases where the CT scan is not able to catch up, because at least it has to be more than 1 centimeter of a lesion to catch, and the primary carcinomas are notorious for the microcarcinomas which are less than 1 centimeter. So in this case you can even go for a PET scan, but that is an advanced test and you write it in the end only. Okay? This is how you will investigate the case, and then you will do the treatment. Based on this disease, what will be the treatment, that we'll discuss in the end. The treatment of all we'll discuss in the end. Okay? That is with the papillary. Now we come to the follicular carcinoma. We'll discuss these both and we'll take note. A follicular carcinoma is of the age group 40, around 40 years. Okay? Again, most common in females. It can happen in males also, but papillary is mostly happening in females itself. Okay? Then it usually happens that there is one thyroid swelling. A patient has come to you, there was a thyroid swelling, and you do the ultrasound, you find it as a solitary cystic swelling. The solitary cystic swelling we usually do, we have written that FNAC therapeutic, there we have written in thyroid function test. You simply just take out all the colloid material, the cyst sometimes collapses back and everything goes normal. But in some cases that swelling, it starts increasing in size. So the patient will come to you, Doctor Saab, फिर से बढ़ रहा है, फिर से कुछ हो रहा है. At that time, a doctor should not say it's nothing, you will be fine. You should always be suspicious of any swelling that is again growing. So it happens usually in a case of solitary cyst, multinodular goiters, or it can happen de novo, it can happen just as on its own. Now the follicular carcinomas, the diagnosis, it will remain the same. You take the patient for ultrasonography, clinical history, that all part is same. Now again comes for the FNAC findings. Now, is FNAC useful in follicular carcinoma as useful as it is in papillary? It is not. And the reason is that on FNAC, what you will see is the follicular cell. And the bad thing about this carcinoma is it doesn't show the features, much of the pleomorphism. Basically, the malignant features are missing. Okay? You might see mitosis on this and that, but that can also present in follicular adenoma. All you get to know is from an FNAC in case of follicular carcinoma that it is not a cyst. It is not a multinodular goiter growing back again. It is a follicular lesion. So when you will write about FNAC, there you will write down as a point follicular lesion. The term to be used is follicular lesion, not carcinoma, not adenoma, just the lesion. That is how you will write it in the FNAC finding. Then in the next part, you might skip CT scan or you might go depending on the history that is given. But otherwise, the patient, if it is a follicular, you directly take the patient for the surgery. It is removed. Then again on the histology, the biopsy is done. There you get the diagnosis of follicular carcinoma or adenoma. Okay? The features, how do we label it as follicular carcinoma or adenoma? I'll show you. It is a little complicated to understand. Say here is a lesion. And this follicular lesion, even if it is a carcinoma, it is kind of capsulated only. Adenomas are very well capsulated, thick capsulated. You'll take it out just like a small toffee. It comes out like that. Very, very well defined. Carcinoma, it might have some blurry margins, but again, there is a capsule around it. Okay? Now, inside this is a lesion. There are blood vessels also in this, and there are lymphatic vessels. Okay? The hallmark of follicular carcinoma, what we call is as angio invasion, okay, and lymphatic invasion. Now, in this particular carcinoma only, if there are blood vessels inside, they are definitely there. Angiogenesis is there, is a hallmark of neoplasm. So there, if the tumor has invaded any of this any of the capsule within this, say here you look at the, here you find it, this will not consider as carcinoma, as a feature of carcinoma. Okay, because it is right in the middle of it. Here there is a lymphatic invasion, no. So what you have to write, because you don't have to see a slide or diagnose it, but what you have to write is, it has to be beyond this here in the capsule. So when as a surgeon you are going to write down, it should be resected completely along with some of the short form used is ETE tissue, extrathyroidal extension tissues. That also you have to remove. So in case the invasion is present in this area, capsule and beyond, that is when you will call it as a follicular carcinoma. Otherwise, it is going as a follicular lesion in case of doubt, otherwise, or follicular adenoma. Okay. If it is a follicular adenoma, simply you have removed the cyst and you have removed the lesion and everything goes fine. Now the doubtful cases come with follicular lesions. After you remove it, then there is again a doubt, it is not clearly indicated. Next, what you do is, what will you do next? You want to be sure that was it malignant or not. Sometimes it might not show the features. The invasion has not yet happened. It might happen over the period of time, but you have removed the lesion. बायोप्सी में तो आया ना ये तो हमको FNAC में नहीं दिखता. FNAC में you cannot see these things. FNAC is nothing, just like you draw blood from your body. Similar way is the FNAC. You just draw some thyroid tissue. It doesn't come in a well-defined format. No blood vessels, nothing. You can only see cells. Cytology, that is just study of cells. That's it, not tissue. Tissue comes biopsy. Biopsy, or this is it, dissection. What next you will do? There is a follicular lesion. There is a doubtful follicular lesion. Lymph node तो मेट जाते ही नहीं है, हेमाटोजेनस स्प्रेड है, हुआ ही नहीं है. निकाल लिया ना, भेज दिया बायोप्सी में, आ गया, यही तो पड़ा है. What next? See, if there's a follicular lesion, it might metastasize later. है ना, पेशेंट को 6 महीने में पेन हो रहा है बट उसे पता ही नहीं क्यों हो रहा है, आप क्या करोगे? गिव मी 1 minute टू सेटल, सोचो, व्हाट विल यू डू? Partha and Ankit, you are talking about the markers. The markers here will not be positive. It will only be positive. The alkaline phosphatase only be positive if they are METs. But I'm not saying that there are METs. I'm just saying that what will you do next to be sure? Socho. See, in most of the thyroid carcinoma patients, there is one unique test that happens later. You either give patient radioactive iodine again, and wherever there is active thyroid tissue, it will take up the iodine, which you can see it on the scan. It's a full body scan. That is what you do here. Next. So in case there is any METs or any left out tissue, that is what you have to be sure of. Jo nikal gaya, either it's malignant or anything, that doesn't matter. We don't do any chemotherapy here. Any radiotherapy, external beam or anything will only be for the METs. So you just have to rule out the METs, that there are no active METs, and you repeat that after 6 months also. Okay? You educate the patient. You tell them that in case there is any continuous pain in any of your bony area or anything, you just come to us. It has to be investigated. That is what you do next. All right. The purpose of teaching all this is that in case you get a case study with specific history, there you should know what you have to do the next. These are the two. And then there is one anaplastic carcinoma arising from the follicular epithelium. The anaplastic carcinoma is nothing but the very aggressive or high grade, very poorly differentiated carcinoma, which is difficult to tell which type of cells are these. Okay. Characteristic nuclear appearance, if there are present, and even if it is anaplastic, we call it as papillary in case there are papillary features. But in case you're not able to make out any features, we call it anaplastic. Highly aggressive tumor, and to plan it as a surgical resection or not, that depends on the METs, if they are present or they are not present. If they are absent, it is just one anaplastic tumor that you have taken out. You just do a follow-up of the patient, right? And anaplastic, this I'm talking on the FNAC. And in case there are METs present, then sometime you have to go for a palliative therapy. That depends on the staging of the carcinoma, which we will discuss after this. All the treatment part staging we'll discuss after this. Till now you just discuss about the clinical part. Okay. Then you have got medullary carcinomas. What are the medullary carcinomas? Arising from the parafollicular cell. इतना तो बोल दिया करो कि arising from the parafollicular cells. Okay. And okay, one thing before we proceed to medullary, there is one oncocytic variant of this carcinoma, follicular carcinoma. There is one oncocytic variant also. Okay, that will write in the FNAC only. That is nothing but the large size cells are present. Okay. The next is the medullary carcinoma. I'll get back to the medullary again. The medullary carcinoma, they arise from the parafollicular cells. The parafollicular cell which secrete calcitonin. So calcitonin becomes one of the marker. Now the medullary carcinoma, it can be sporadic, or sporadic means it is growing just on its own, or it can be part of a neoplastic syndrome, MEN type 2. You read about MEN type 1 and type 2 syndromes. So it can be part of MEN type 2 syndrome also. Okay. In case the medullary carcinoma is associated with any more mucocutaneous lesions, then it is a part of Sippel syndrome. So sporadic, it is called Sippel syndrome or MEN2 syndrome, or it can be a Sippel syndrome also. This is a clinical picture that you might be given. They can ask you MEN syndrome because tumors of adrenals are also in your syllabus. So it can be asked in that form also. Now the medullary carcinoma, they are the neuroendocrine tumors, so they also additionally secrete serotonin, ACTH, so that symptoms can be related to the release of these markers. And apart from this, the carcinoembryogenic antigen, CEA, is also released in this tumor. It is not specific for this tumor, but you get these levels checked before treating the patient, and it can be used as a tumor marker also. after the treatment, just to see how's it going. And also we see calcitonin. Now, what is the role of calcitonin? It causes what? Hypocalcemia. Okay. So, but medullary carcinoma patients, it does cause it does not significantly causes hypocalcemia somehow for some reasons, and the reasons are not clearly known. It is believed that it is happening so quickly that there's not enough time for this to happen. Okay. So, but calcitonin will be present. So, do not write about the bone resorption because it is very, very uncommon to have brittle bones in this case. Okay. What else? What else can happen? I've told you the features serotonin, ACTH will be there. What other features can happen? No. The similar features of the men type 2 syndrome, if it is happening with along with it, those features can simply happen. Okay, there can be renovascular hypertension, these kind of things. We'll discuss. I'm not discussing it right away because these are not prominent features of this carcinoma. You'll get confused. So to say, treatment again, it goes for surgical resection and everything. And but the prognosis is not very good. It can sometimes go very advanced. Neuroendocrine tumors, wherever you read, the prognosis is not good. Yeah, the prognosis is just, you can say, fair, not good. If it is early diagnosed, it can be good. Surgical resection and the same. Now here the radioactive iodine part does not work after the surgery, just to look, because it is not a follicular, it's a parafollicular cell. Okay, so the markers are different. All right, this is just a brief about the thyroid carcinomas. Lymphomas, you don't need to study here. The lymphomas will read otherwise as separately with leukemias. I'll just briefly discuss on that. They're not going to ask you lymphomas, it's the rare tumors. Okay, you stress only on the three: papillary, medullary, and follicular. All right, quickly take notes, then we'll make the flow chart and we'll also memorize the TNM staging. Right on, papillary carcinoma, thyroid. It is the most common form of thyroid carcinoma. Most common form of thyroid carcinoma that arise from follicular epithelium. Next, write down clinical features. Young females in the age of 20 to 40 years. Young females in the age of 20 to 40 years are commonly affected. It can present as a solitary nodule or as microcarcinoma or occult carcinoma, where the tumor size is around 1 centimeter and it is not palpable. Lymph node metastasis in the next line. Lymph node metastasis is common in the cervical region and sometimes lymphadenopathy is the only clinical feature. Next item, diagnosis. First is the clinical examination. In clinical examination, you will write about thyroid nodule. A nodule can be confirmed to be of thyroid origin, if it moves with deglutition, then write on the next point, the cervical lymph nodes may be palpable. In advanced cases, there can be hoarseness of voice, dysphagia, difficulty in swallowing, full stop. Next, write down in diagnosis, ultrasonography. In this, write down. The typical features will include presence of papillae, and microcalcifications. Next, write down FNAC, fine needle aspiration cytology. In case of occult carcinoma, ultrasound guided, USG guided FNACs are done. In the next line item, the cytological features of papillary carcinoma are cytoplasmic inclusions, put hyphen and write down intranuclear, then next write down the cells are cuboidal and pale. Next write down in the nuclear features, the nucleus shows characteristic clearing, leading to ground glass opacity, what do you understand by ground glass opacity? X-rays में सुनते हैं, what is that? Ground glass opacity, what does it look like? Translucent. How do you explain that? Give me some example.
Comparative to surrounding tissue.
Ground glass, okay, see, very simple. You know what is glass, okay? You keep a glass over here, I'm moving, I know this is the ground, this is not the ground, because some kind of reflection it is throwing. That is simply ground glass, okay? So here also I said, no, it will be pale, it will not be like completely transparent, it will not be completely opaque, it is translucent. That is a ground glass opacity will be there. And put a hyphen and write down called as orphan any appearance. orphan any appearance. Then in the FNSC only write down, also seen are calcified deposits. Here you will not write samoma bodies because samoma bodies is finding of biopsy, not of FNSC. Okay, calcified deposit, but in the bracket you can write down can be samoma bodies. You know the spelling of samoma? We have written cytoplasmic features, we have written nuclear features, we have written calcification. Last write down cystic changes or necrotic debris in FNSC only. Okay. Then next write down investigations. You've done this, you've done this. Next on CT scan. CT scan, it is done. It is done in cases of clinically advanced diseases. Clinically advanced diseases. Full stop. Okay. PET scan, no need to write. You just write down, but do not write out in every case. Okay. Where only there's a meds are given, only there you write about PET scan. Okay. Next, write down the treatment. You just write it down over here. In the end, we'll discuss it separately. First write down total thyroidectomy. Total thyroidectomy or lobectomy is the treatment of choice, is the first line treatment depending upon the size of the lesion, full stop. However, recently total thyroidectomy is preferred for the following reasons. First is easy to detect and treat residual metastatic disease. Then easy to detect recurrence by thyroglobulin level estimation. Next point is eliminates the risk of resurgery or contralateral carcinoma. Full stop. Next, what I have written total thyroidectomy and advantages, right? Okay. Right on. Next is the second one, treatment of secondaries. This is a treatment of primary, treatment of secondaries. In case of metastasis to cervical lymph nodes, in case of metastasis to cervical lymph nodes, radical neck dissection, not radical, sorry, N block dissection is done. This is N block. Dissection is done. Okay. Then in case the adjacent structures are involved, they are to be removed. Then the next one is third part of the treatment is suppression of TSH. Right on. Papillary carcinoma is a TSH dependent tumor. So in post-operative period, TSH is suppressed prophylactically by administering thyroxine 0.3 milligram per day. 0.3 milligram per day. Full stop. Now thyroxine is T3. Here we are talking about giving T3 to suppress TSH, right? Right on. T4 replacement can be given to the patient, patients who do not require radio ablation or radio iodine for scanning post-operatively. Okay, that is about the papillary carcinoma. Now we go to follicular carcinoma. AC बंद करवा दो थोड़ा, AC बंद करवा दो. And follicular carcinoma. In this you first write down the follicular lesions. The follicular lesions can be benign and malignant. And show similar cytological features. And it can be confirmed, which can be confirmed only on biopsy. Now this line what you have written, just put it in a bracket, and this is for you to remember. It is not to be written, okay? For you, only for you to remember, so that you do not use the term follicular carcinoma. I am repeating this word again and again because students tend to do it. You know that the diagnosis is follicular carcinoma. You start with writing the answer. So students straight away start with follicular carcinoma. What is your diagnosis? Follicular carcinoma. No, that will be established in the end. It is follicular lesion first. Okay? So you have to call it follicular lesion only till you establish in your answer that it is a carcinoma. Okay? And if you have to write down the diagnosis, say the first question is what is your diagnosis? 1 mark question. There you cannot write simply lesion and then you later say, there you will write it as follicular lesion, most likely malignant. Then you proceed with the answer. Okay. But with the papillary lesion, there are no benign lesions. There is no confusion. Only in the cytological examination, you can simply say it is a carcinoma. So this line is for you people only. Okay. Now we will start with the notes. Follicular carcinoma accounts for second most common thyroid carcinomas. Second most common thyroid carcinomas that occur in the age group of age group of 40 to 50 years. The carcinoma can present as solitary nodule or can arise in the setting of multinodular goiter. Multinodular goiter. Next line. It can also present as metastasis in the flat bones, where the patient presents with chronic pain, full stop. Now again, here also we'll follow the same pattern. Next is diagnosis. How will you write about the diagnosis here? I have told you papillary. You tell me about this one. How will you write the diagnosis here? How will you write? Clinical features. Okay. Then what next? Ultrasonography. What will be the findings? Okay, cystic lesion. That is only in case of murder. Huh?
Will be of thyroid origin.
अल्ट्रासोनोग्राफी पे कैसे बताओगे? It is very difficult. This is a very basic investigation. Papillae तो दिखते हैं, they can be seen. That is why we have written papillae. Microcalcifications. All the carcinomas will show microcalcifications. Then cystic changes can be seen. Then there will also be a solid mass. अब एक carcinoma है तो कोई solid mass, वहाँ papillae थे, there will be at least some solid mass that will be seen on ultrasonography. First is clinical features. Then the clinical features I have already dictated, they remain the same. Then ultrasonography, the findings will be of a solid mass along with cystic features and microcalcifications. Next we'll do the FNAC. The FNAC is done from the solid lesion. The FNAC is done from the solid lesion, and it shows follicular cells with low to medium degree of pleomorphism, cystic necrosis, full stop. In this only write down the benign lesions cannot be differentiated from the malignant on FNAC. Full stop. So all the follicular lesions are overtreated as follicular carcinomas. Okay. What next? Investigation. The follicular carcinomas actually they spread to the bones. We have read about the metastasis. अब bones में spread हो रहे हैं तो क्या diagnosis क्या investigation करेंगे? PET scan सीधा. PET scan is very expensive. ठीक है? It needs have you seen ever PET scan? How is it done? Okay, we'll read about it. You give some kind of material to the patients. It is very difficult procedure. It is not very simple. So that is why PET scan is done very occasionally, and in a private setup somewhere in India, it's like 25 to 30,000 just for one scan. ना? तो उससे पहले तो X-ray 250 rupees. Why go for the bigger one? Also, you are unnecessarily exposing the patient to different radiations. No? So we are talking about the meds. We'll go for X-ray, bone scan. We can do alkaline phosphatase levels. In all the bony lesions, anywhere it happens, whenever we are going to read about the bony lesions, alkaline phosphatase levels will be high. Okay. What else? Now we can go for the CT scan also, but not PET scan. Okay. Write down. X-ray. In case of metastasis or any chronic pain, the X-rays can be done, which shows osteolytic lesions. Full stop. Next is alkaline phosphatase levels. The levels will be increased in case of bony metastasis. Then very written X-ray, just write on one, nothing. Okay. Then next is bone scan. It is also to look for metastasis. Last is the CT scan. Okay. One thing we forgot to write here, separately write down metastasis of follicular carcinoma. Okay. Follicular carcinoma usually metastasize via hematogenous route. To the flat bones such as skull, ribs, skull, ribs, vertebral column, and sternum. And sternum. Okay. Next, write on the treatment. Now with follicular carcinoma, there will be different type of scenarios. Depending on your scenario, there will not be a direct question of follicular carcinoma, what is it? So we are going to discuss about the scenarios and we'll write the treatment according to it. Okay. So first write down, in case of say multinodular goiter or just cystic, when it is happening in the cystic changes. Okay. Because the diagnosis will be on FNSA will be of follicular lesion. So in that case, how will you overtreat? You overtreat the patient with this write down. When it happens in the setting of multinodular goiter or solitary cystic nodule, either subtotal thyroidectomy, no, just write down total thyroidectomy. Total thyroidectomy is done. Full stop. Okay. In the next line, write on, in case the follicular carcinoma is an incidental finding, where subtotal thyroidectomy was done for multinodular goiter or solitary cystic nodule. In that case, total thyroidectomy is done. Total thyroidectomy is done either within 7 days, or after 4 weeks. Now the reason is that the process of inflammation in the thyroid gland, it also involves fibrosis. So when there's fibrosis, it becomes difficult to resect the thyroid without injuring the laryngeal nerve. So that is why we do it either within 7 days or after 4 weeks when the inflammation is resolved. That is the fibrosis time. When that is resolved, we do it then. Okay. Next situation is when there are mets. Okay. So in this, write down, in case of follicular lesion with suspicion / confirmation of mets, total thyroidectomy is done. Followed by radioiodine ablation therapy. Followed by now next part, right? These are just the scenarios. So whatever is your case history, you proceed according to that. Next, give the heading of management of metastasis. Management of metastasis. In this case, just write down, after surgery, a whole body scan is to be done. A whole body scan is to be done to look up for metastasis using radioactive iodine In case of a single secondary lesion, the treatment is oral radioiodine followed by radiotherapy. Then next is if multiple secondaries are present, they are treated by only oral radioiodine. Now again, as it is the follicular carcinoma, it is also TSH dependent. So the third part is the post-operative thyroxine, post-operative suppression of TSH. Same write down as we have written in the papillary carcinoma. Next, quickly take up the notes of for medullary carcinoma of thyroid. These are the thyroid tumors. These are the thyroid tumors that arise from parafollicular or C cells. Parafollicular or C cells. The tumors can occur in two ways. One is sporadic. They are like 80% of are in these, or associated with men type 2 syndrome. When the medullary carcinoma, next slide, when the medullary carcinoma is associated with mucocutaneous neuromas, it is called as Sippel syndrome. Okay. These tumors are not TSH dependent. Next line, these tumors are not TSH dependent and they do not take up radioactive iodine. Just put this line in the bracket. This is only for your understanding and learning. Now write down diagnosis for the medullary carcinomas. The carcinomas, first is the clinical features. The carcinoma can present as solitary nodule, or in association with men type 2 syndrome. Next, write down. Next investigation will be same ultrasonography. It will show a solid lesion. Along with amyloid-like inclusions. Okay, full stop. Next is FNAC. On FNAC, the tumor shows pleomorphic cells mixed in, again same, amyloid stroma, comma necrosis, okay. Next investigation, right on. You will do serum calcitonin and CEA levels. What is CEA? Carcinoembryonic antigen. So when the calcitonin is released, so calcitonin will be high, CA is high. There is already suspicion of, because of the presence of this amyloid stroma, there is already suspicion of the medullary carcinoma. Okay. Next, you can do the CT scan only if there is doubt of metastasis. Next heading, write on metastasis. The medullary carcinomas spread via hematogenous and lymphatic route. Full stop. So the mets, basically you can find the lymphadenopathies, you can find it in bones, lungs, liver, everywhere. Okay. So now the metastasis is such widespread and common, that means the prognosis is also poorer as compared to the other two carcinomas. Okay. Then treatment. Now because it metastasizes quickly, so the treatment of choice is always total thyroidectomy with radical neck dissection. In case it is next line, in case it is associated with pheochromocytoma or MEN type 2 syndromes, then it is treated accordingly. Okay, now quickly we come to the TNM staging of thyroid. The TNM staging, those who do not remember and those other people, T means tumor, size, location and extension, whatever. Nodal, okay. How many lymph nodes, and this is distant mets. Okay. So the TNM classification you need to know to understand the treatment part. Treatment, what you have written is right. If the individual carcinomas come, you write it like that. In case they ask you on the approach to thyroid carcinomas, okay, or make a flow chart or make an approach or manage, there you should know about the TNM classification. You might not write it, but they can give a clinical history and say approach to thyroid carcinomas in general. And UPSC has been in last 2 to 3 years has been asking some vague questions, open-ended question, where you will not be able to guess out if it's a papillary or follicular, but you might be sure that's a thyroid carcinoma. Okay, so they leave you hanging in between. So now how do you have to proceed? So this year in this course, I'm covering those part also. You have written the treatment, but the basic flowchart to a thyroid carcinoma. How will you proceed? So that is why we are going with the TNM classification of this. Otherwise, it was not needed. This is the extra part. So TNM, you quickly start writing. I'll dictate and then we'll discuss. Even if we don't discuss it today, we'll discuss it in next class. But I'm going to go a little fast in last 10 minutes. TX means the primary cannot be assessed. That is the, you cannot look for the primary tumor, TX. Then is T0. T0 is no evidence of primary. There is no evidence of primary. Then T1. T1 is the tumor is limited to thyroid and is 2 centimeters or less. Then T2, again limited to thyroid and is more than 2 centimeter to less than 4 centimeters. Then T3 is limited to thyroid. I don't limited to thyroid, but more 4 centimeters. Then T4 is extending beyond the thyroid capsule, irrespective of the size. And then there are two other parts of it. One is moderately advanced, then is very advanced. Okay, some people here moderately advanced, they say that it is extending to the nearby structure, the larynx, the cartilages nearby. And in very advanced, they say it has extended to sternocleidomastoid, the jugular veins, the carotid area. But this classification is very blur, and it is up to the clinician how he wants to say it. So it is not clearly mentioned, but roughly they call it this. So this is for your understanding only. You can write down for your understanding in case the approach, because the approach changes here. Okay. Next we go to the nodals. N0. N0 means no regional lymph node metastasis, and then here regional lymph node metastasis is present in N1. Now N1 is also further of two types, 1A, 1B. In 1A it is including all the cervical lymph nodes, all the levels, and 1B is two lymph nodes beyond cervical lymph nodes, any other lymph node. Then we have M0, M1. M0 is no metastasis, M1 is metastasis is present, and there is no further categorization. Okay, now you have written TNM. We'll do the staging part. This is just only a TNM, what we write here. It only tells what is the current clinical stage of the patient and how it is going. But the staging is when we stage it as 1, 2, 3. The layman also asks, kya stage hai? So that is the staging. Now the thyroid carcinoma, the staging, because the prognosis, it changes a little with the age, 45 years more or less, like that. So the carcinomas, thyroid malignancy in less than 45 years of age and more than 45 years of age. So firstly we'll discuss this. Okay, it has got stage 1 and stage 2. So write on stage 1 is any T, any T, any N and M0. Then here it is any T, any N and M1. There are only 2 stages for less than 45 year of age group. Now more than 45 years of age group, stage 1, it is at stage 1 when we have got T1, N0, M0. Then stage 2 when we have got T2, N0 and M0. Stage 3 when we have got T3, N0, M0. Now we have got on stage 4A, 4B and 4C. Okay. In 4A, first one you write down T1 to T3 and then write down T4A. 2 parts are there. In T1 to T3 plus up to N1A and M0. Here there is T4A and N1B. Up to N1A it is here, then it changes here and it is M0. Then in 4B you have got T4B. T4B was very advanced, and any N and M0. Then 4C is of course T4B and beyond, anything, any N, T4B and beyond. And here we have got M1 with up to anything here. That means that's a distant metastasis is present, that is a stage 4C. This classification that you have written is for the papillary and the follicular carcinoma. Medullary carcinoma, it is not important and unnecessarily confusing, so we'll leave that. You only memorize this staging. Okay. Now based on this, we'll make a flowchart for approach to thyroid carcinomas. Okay. This is basically the latest that is being followed, and this was given just last year only. This is followed, this is the latest criteria. But you write, I've given you the mixed note of your books and this because just in case the teacher has not read the latest criteria or they have read it, but we'll make the flowchart including both. The correct things only we are writing. Okay. So we'll start with T1 and T2. Okay. In T1 and T2, you'll first go for the history. You can write on in this side what all history you will be asking. You will ask for the history of any previous radiation, any history of Any family history of thyroid carcinoma? And last one is the aggressive features on FNAC. Now, if the history is negative, we'll go with lobectomy. In case any history is positive, we'll go with total thyroidectomy plus prophylactic. You have to use the term prophylactic central neck dissection. Prophylactic central neck dissection. ठीक है. Now I have done the lobectomy over here. History was negative. ठीक है. But the lobectomy will go for the histopathological examination. So here we proceed. That is, it has gone for the, just write down histopathological examination. Now, if histopathological examination suggests of any extra thyroid extension, any evidence of vascular or lymphatic invasion, and aggressive tumor like anaplastic or something different has come up, then in this case the treatment will go back to here. You'll have to proceed with total thyroidectomy followed by prophylactic central neck dissection. ठीक. Any confusion so far? Next we come to T3. If it is T3, we will do total thyroidectomy plus any extended resection if needed. In case once you open it, you see that the tumor has spread further, that is to be done. Plus again prophylactic central neck dissection. Next we have got N1A and here write on N1B. N1A will have total thyroidectomy plus bilateral therapeutic, not prophylactic, therapeutic central neck dissection. Then N1B, that is the mets have gone outside the cervical lymph nodes, right? So here we'll do total thyroidectomy plus bilateral central neck dissection plus therapeutic wherever the nodes have gone, compartment lymph node dissection, therapeutic compartment lymph node dissection. Now, in these cases, what next we are going to do? अभी तो हमने सिर्फ थायराइड जो दिख रहा था अभी वो ट्रीट किया है, बट नाउ ऑल्सो बिकॉज these are already the aggressive one, we are already going with aggressive route, we'll go for a whole body scan for metastasis, right? Whole body scan for metastasis. If it is negative, it's okay. If it is positive, then you know, oral radioiodine, write down. If it is positive, we'll give oral radioiodine and we'll use external beam radiotherapy. External beam radiotherapy. And in both of these cases, irrespective of metastasis, we need to give hormone replacement therapy. Now, one thing is left, one scenario, that is T4, which was metastasis was present. It was with extension and everything. So in this case, we usually give only external beam radiotherapy. Clear? I'll just explain the chart once again. For T1 and T2, where the thyroid is, where the tumor is limited to the thyroid and is smaller in size, we'll go for the history. If there is any previous history which is likely to show that the tumor might be aggressive or it might be predispose the patient to recurrence, there we'll look for the history. If it is negative, we'll go for the lobectomy and we'll wait for the histopathological. If it is positive, we'll go for total thyroidectomy as well as prophylactic central neck dissection. Prophylactic because there is no evidence of any nodal metastasis, but we are doing it. And in case if any of these is positive, we'll complete the thyroidectomy followed by this. We'll do again a surgery. Next, if it is a T3, then we will do total thyroidectomy plus extended, what is written here? And extended resection of the neighboring tissue if it is present, and prophylactic central neck dissection. Now here we will do total thyroidectomy. If it is there's a nodal metastasis, we'll limit it to the cervical lymph nodes and we'll do a bilateral central neck dissection. If it is beyond, then therapeutic compartment dissection will be added apart from the central neck dissection. If it is T4, external beam radiotherapy. All the cases we will look for the evidence of any metastasis post-operative. Negative, it's okay. If it is positive, oral radioiodine and external beam radiotherapy and hormone replacement for all of these. Okay, here we are not adding because we are not even taking it out, the thyroid. Clinically we can assess the situation. If needed, we can do it. Any doubts? Now we finish with the thyroid. All right, okay. In the next class we'll start with mammary gland, and before starting I'll also briefly discuss about metastasis, the process of metastasis in general. So read about the mammary gland, the lymphatic drainage, the gross anatomy, make diagram of the lymphatic drainage importantly. Just read about it and we'll discuss it. Assignments submitted here, and you can also submit it online on the email ID that has been given to you. Any?
Memory gland blood supply assignment.
Blood supply, lymphatic drainage, yes. Whatever you want to study, basically you have to read the whole of it, whatever you want to send. Okay. Shraddha hai aapki. Okay. See you all on next Wednesday. There was one student who has problem with the classes on Friday. We'll see in case there is any change, but for now it is Wednesday and Friday evening. Okay then. See you all.